Bob has been a victim of modern dentistry. He used to be a fighter pilot in the United States Air Force. If I'm incorrect on anything, Bob, please tell me. Bob has taught me a tremendous amount of science and information concerning patient health, heavy metals, jaw, bone diseases. He is the inventor of the Cavitat. I have used that for, 5, 6 years in my office now. Been a phenomenal tool for me. So please give him a very warm welcome.
In 2002, the FDA asked Cavitat and our scientific advisory board, which Mike and Bill Glaros, Mike Margolis, Bill Glaros, and several others are party of, to do a study underlying the levels of ischemic osteonecrotic lesions as we imaged them with the Cavitat. Dr. Glaros and Dr. Margolis have not heard this lecture yet, so this is coming as a surprise to them of what I'm going to say here. But in 2002, May of 2002, we did a 392 patient study. They were on the blind side of it. They were sending reports in to Dr. Jerry Bocco, and Dr. Wes Shanklin was one of these from up in Ohio. And we uncovered a new disease factor that we aptly named focal osteoporotic marrow defect, FOMD. When we looked at this thing in 392 patients, we found 339 of them had this FOMD problem that we defined, because we'd never seen it before, but the Cavitat readily lesions showed up very well on the Cavitat. What FOMD is in a focal osteoporotic marrow defect is a widely spaced osteocyte in the cortical plate and vital part of the bone, and then underneath it's all trash. Necrotic, osteoporotic, and everything that goes along with that was occurring. When we ran them back through the statistician computer to confirm this, we found that 339 of them were taking a bisphosphonate called Fosamax made by Merck. We notified the FDA with a discrepancy report. The FDA called a meeting at Merck's New York headquarters. Two of our scientists attended, Dr. Wes Shanklin and Dr. Bocco. I did not go because I was not needed. I wasn't part of the study, and my instrument was part of the study. So, along with another pathologist from the University of Florida, and we went back to Merck and sat down with the FDA and Merck in May of 2002. Now this is important, okay? Merck convinced the FDA that since our study only represented 1 to 1.5% of the prescriptions written, no patient referred to it, just prescriptions written, that what it was designed for, which was to restore calcified bone into areas that had been destroyed by metastatic bone cancer. In this, it works fairly well, but it does not work the way Merck presented it to the FDA for their clearance, and I'm going to cover that today. Now, FDA says, okay, you can keep the drug on the market because the good is worse than the bad because of the percentages of people involved. 6 weeks after we're there, Merck started marketing it over the internet, over the mass media, the TV and the journals, as an osteoporotic drug. It does not work as an osteoporotic drug. It doesn't work that way. 2.5 million prescriptions a month are being written for Fosamax. All the women that see this go into the physician and say, I need to be on this because I'm worried about osteoporosis. I don't want to have a dowager's hump. I don't want to be crippled up in later life. Well, at the time that we reported to Merck, they had about 2.7 million people on the drug. Now, we got 38% of the women and 11% of the men over the age 30 on it. Well, the percentages just went up. We're talking millions of people now. There is a class action lawsuit. It's going to be bigger than tobacco, and don't get caught in this lawsuit, and that's what I'm going to cover today. Everybody understand where this talk came from and what we're doing. Most of this research was done by the National Academy of Sciences and a research scientist by the name of Thyssen. And I've taken a lot of their work and adapted into what I've done and what we've done as a scientific committee and the stuff we reported to Merck. And I'm going to show you some things that are taking place and some of the underlying causes, and that's what we did. This disease is irreversible. It produces a condition called phossy jaw, which is a death of the jawbone by phosphorus compounds. And it's just like the matchmakers back in manufacturing matches in the early 1800s when they started going to the striking match deals. They were taking and touching this stuff to their mouths, and they were picking up the phosphorus compounds, and they end up with phossy jaw. We've known about phossy jaw for a long time. But this one is a chemical induced also, but it's done in a way that is very alarming, and once it's reached that stage, if you try to extract a tooth, you're probably going to pull out half the jawbone with it. It is irreversible. If you get a patient that comes in and you got a patient consent form, please ask that question on that patient consent form when you're getting information. Are you on a bisphosphonate drug such as Fosamax and the others I'll list up here? There's 9 manufacturers now. If they are, your best bet's refer them to a medical doctor. Let the medical doctor be the one on it, because if you do some dental work on this person, you're going to get hung out on the liability. You're the last person to see them, and this will occur with these underlying causes in 87% of the people. The half-life on bisphosphonates in the bloodstream is 29 years if you've been on it for more than 2 weeks. Now, this is why I say clear and present danger. But you have got to protect yourself, and you've got to be aware of what's going on. Now, I'm going to start in my talk. I don't have a lot of time today because this thing is very complex and stuff, but it's going to shock you on what I've got here. It's all done by the National Council of Scientists and this Margaret Thyssen on most of this stuff I got up here, and the rest of it is my bisphosphonates. A new challenge is service that leads to major decisions and treatment protocols for both in dentistry and medicine. The introduction of bisphosphonate drugs has created a terminal illness, or so it seems. Bisphosphonates were introduced by Merck in 1992 to be used for helping metastatic bone cancer patients rebuild degenerative damaged bone and to help alleviate the pain that this condition causes. Worked very well for that, but not in the way they thought. While the drug seemingly worked very well, there were some serious side effects that would come to light in the passing years. Cavitat and its board of scientific advisors, which most are members of this academy, while pursuing a study for the FDA request of outlining levels of bone lesions 0 to 4 as determined by Cavitat imaging, uncovered a new condition we named FOMD, or focal osteoporotic marrow defect. The condition, readily imaged by the ultrasound of the Cavitat, presented a unique bone structure which we had not seen before, a dense, hard, brittle cortical plate, or bone, with very widely spaced osteocytes and a varying level of porous bone. Beneath the dense layer of vital bone, at first we thought we were lost to explain what this condition represented, but when we ran a computer study of statistics, 339 of 392 were taking a drug known as Fosamax by Merck. When you get into those type of numbers, when you start showing that 100% of these people is scientific fact, it is no longer in question. So more evaluations were done, and a total of 314 additional patients were evaluated. What was found was all the patients that exhibited this condition were all taking a bisphosphonate drug. This, needless to say, got our attention. After confirming there was a link, an adverse reaction report was filed with the FDA, and a meeting was called to take place in May of 2002 in Merck's New York headquarters, as I said a while ago. Merck reported in lieu of the study, it would only amount to 1% of the prescribed doses, and convinced the FDA it did more good than harm. and they then proceeded to aggressively market the drug for osteoporosis, advertising its mainstream media for an antiporosis drug. Now 38% of the female population is taking this drug. An additional 2.5 million prescriptions, or it should be prescriptions, they've got subscriptions, are being written every month, and now we're faced with a crisis and a new class action suit on behalf of victims of this tragedy. This class action suit will be bigger than tobacco, and Merck will not be the only defendant, as there are underlying conditions that triggers this event of phosphy jaw. The Academy of General Dentistry has put out a position on this, and my brother's handed out some reports to you. This is the Academy's position, and since this is an AGD-approved credit hour course, I want to bring up their position. I agree with 99.6%, but there's one topic in here, and I'll get to it, and you'll know what it is when we get there, that I don't agree with, because anything you do to this patient is going to cause problems. Academy of General Dentistry says treatment drug may cause jawbone to die. That's pretty blunt. Breast cancer patients, individuals at risk for osteoporosis, and individuals undergoing certain types of bone cancer therapies often take drugs that contain bisphosphonates. Be done intravenously or by oral. Bisphosphonates may place patients at risk for developing osteonecrosis of the jaws, eroding the jawbone. According to a case report and literature review that appeared in the May-June 2006 issue of General Dentistry, the Academy of General Dentistry's AGD, clinical and peer-reviewed journal. Bisphosphonates are a family of drugs used to prevent and treat osteoporosis, multiple myeloma, Paget's disease, that's a bone cancer, and bone metastasis from other cancers. These drugs can be bound to the bone surface and prevent osteoclasts that break down bone from doing their job. They also prevent an osteoclast to osteocyte conversion. It slows it down, allows the drug to build more calcium in the bone. This is the way it works. It doesn't stop osteoporosis. It allows them to rebuild, but with widely spaced osteocytes. Healthy bones constantly rebuild themselves, explains the co-author of the report, Sally Jo Plaka, DMD, MPA. However, since the jawbones have rapid cell turnover, they can fail to heal properly in patients taking any of the bisphosphonate drugs. Patients need to be aware of the possibility of complications from dental surgery or extractions. Since these drugs linger in the bone indefinitely, 29 years, okay, they may upset the cell balance and how the jaws regenerate and remove unhealthy bone. In their report, the author referred to a case of a woman who received bisphosphonate therapy intravenously to treat metastatic breast cancer. She then developed osteonecrosis in her upper and lower jaws following tooth removal. This type of osteonecrosis has been recurring since the advent of these drugs, explains co-author Wellington S. Ty, DMD. At this time, osteonecrosis as a result of phosphonate therapy has no treatment. It's terminal. Patients who are taking the bisphosphonates should inform their dentist to prevent complications from dental surgical procedures. By informing your dentist that you are taking a bisphosphonate, different avenues for treatment can be explored, says the report's third co-author, Kevin Vahali. It is strongly recommended that patients scheduled to receive bisphosphonates therapy should visit a dentist or an oral surgeon so problematic teeth can be treated prior to the start of the therapy. Widespread use of bisphosphonate to prevent or treat early osteoporosis in relatively young women and the likelihood of long-term use is of concern, says Dr. Plaka. How bisphosphonates interfere with the healing after dental surgery is still unclear. Not unclear. We know how it does now, and you'll learn it today. And further research will be needed. It is imperative that the public understands there is no present treatment or cure. Your patient has got to understand this to cure for this problem. Tips to reduce the risk for osteonecrosis of the jaw and maintain a healthy mouth. Inform your general dentist, especially if you're taking bisphosphonates. Check and adjust removable dentures. Obtain routine dental cleanings. They say here now, opt for root canal therapy over extractions. That is the worst thing you can do because it increases the chance of phosphy jaw by 98%. So this is a sales job to cover up the dental stuff that's going on. The credits for the rest of this talk are primarily done by Kathleen Thiessen, PhD, and this was taken from the SDNES Oak Ridge Incorporated Center for Risk Analysis and the National Research Council of the National Academies of Sciences. There's more information there. I've given you a website. It's www.nap.edu. This is where all the facts of the science are published on this thing. And I'm going to go over now the science that you need to understand on what's going on, because it absolutely concerns you as dentists and medical doctors alike. It is dangerous, guys. It is dangerous. I'm going to give you some definitions. The endocrine system, cellular communication carried out by the classical endocrine glands and their hormones. Endocrine glands communicate with other cells via internal secretion of a chemical signal into the bloodstream. Hormones, a chemical signal secreted in the bloodstream by an endocrine gland. It elicits a typical physiological response to other cells, the target cell. The ultimate mission of a hormone is to change the behavior of target cells. Cellular behavior is determined by biochemical and molecular events that transpire within the cell. These events are determined in turn by the genes that are expressed, and I do a lot of work in proteins and genes. The biochemical reactions that carry out cellular function, the conformation and associations of molecules that compromise the cell's physical structure. The conformation association of the molecules that compromise the cell's physical structure, along with the biochemical reactions that occur. Hormonal messages must be converted to biochemical events that influence gene expression, biochemical reaction rates, and structural changes. Effects of fluoride exposure on hormonal function. When did we start having fluoridated water? 56. Selected parts of the endocrine system, the National Academy's report says that 0.7 of 1 part per million fluoride in 2 months' time induces skeletal fluorosis. Where do we get the most fluorides? From fluoridated water or toothpaste. Right. 0.7 of 1 part per million induces skeletal fluorosis. Now think about what I'm saying. The average water and the average fluoride contains 2.5 parts per million. 2 months, you are inducing skeletal fluorosis. So it affects on selected parts of the endocrine system, basic biology, types of effects, summary of evidence to date, difficulty in interpretation, possible mechanism of action, and potential implications for health are the next topics. The major focus in the National Research Council report: thyroid gland, thyroid follicular cells, calcium metabolism. How many of you doctors got patients that are on taking calcium? The parathyroid gland, the thyroid parafollicular cells, the C cells, the pineal gland, the glucose metabolism. How many of them have diabetes? Type 2 diabetes, 38% of them will have. This has occurred since the introduction of fluoride. Think about what I'm telling you. This all has a reaction on the underlying causes. Normal thyroid function produces the thyroid hormones T4, thyroxine, T3, triiodothyroxine, modulates a variety of physiological processes, including normal growth and development, essential for normal development in the nervous system, dependent on adequate iodine uptake. This is the thyroid hormones, and you notice the binding sites for iodine are expressed here with a little mark with the eye. They got 3 sites bound on the T3. The T4's got all 4 sites bound. Fluoride effects on thyroid function: decreased thyroid function, decreased T4 and T3 concentrations. Seen with fluoride doses of 3 to 6 micrograms per kilogram, that's about 0.7, with sufficient dietary iodine, 0.4 to 0.6. In one study, more severe effects were seen at similar fluoride doses when dietary iodine was not sufficient. Effects seen at lower fluoride doses of 0.06 to 1 when dietary iodine was not sufficient. TSH was not measured in any animal studies. Relieved hyperthyroidism in some patients, goiter prevalence of at least 20% of the people, altered concentration of T4 and T3, elevated concentrations of TSH. This is a South African study that was done on goiter, and the prevalence in the towns is at 2.5 parts per million. Skeletal fibrosis and goiter were very, very prevalent, like 30%. This is a measurement of thyroid hormones for difference in DILs. I'm not going to go over this because it's all basically the same. It's just how it shows. I wanted to put that up there for you to see. And the thyroid effects of fluoride possibly making decreased production of thyroid hormone, effects on thyroid transport in the blood, effects on peripheral conversion of T4 to T3 and normal deionization, inhibition of deionasis. Thyroid effects of fluoride. No, you're shutting the thyroid down. We can't utilize what's there because of the fluorides are bonding to the binding sites. Here's where the problem starts. Possible increase in symptomatic individuals, increased risk associated with subclinical asymptomatic thyroid disease, cardiac disease, increased cholesterol concentrations. How many of them are taking cholesterol drugs out there now? Increased incidence of depression, diminished response to standard psychiatric treatment, cognitive dysfunction. How many of them you see walking around in a stupor? 90% of them. For pregnant women, decreased IQ of offspring. This should be importance of everything. We're bringing on a whole load of kids that are 30% IQ less than the ones that did not have fluoride, okay? Now, where does this go? And this is all going to what we're talking about. The parathyroid gland. Parathyroid hormone increases calcium concentration in the blood, stimulates bone resorption. If your thyroid's working properly and you're absorbing it properly, this is the function it's supposed to do. It's supposed to do what Posamax is alleged to do. Thyroid parafollicular cells, the C cells of calcitonin, lowers calcium concentration in the blood and inhibits bone resorption. How many of you see reabsorbing teeth, okay? Elevated calcitonin in 8 of 9 skeletal fibrosis patients. You notice the levels are extremely high. And the elevated PTH in 4 of 9 patients skeletal fibrosis. And 4 of those are completely out of range. Now, you ask why the difference? Because some of them are living in extremely high areas of fluoride concentration. They got fluoridated water. They're using fluoridated toothpaste. The dentist is using fluoridated rinses. They're drinking a lot of orange juice that is fluoridated. The water from the concentrate and from the vegetables that they're eating that are picking up fluorides that are in the irrigation water. And this is all passed on, and the ones that are in the highest level are the ones most subject to phosphate jaw. And that's the reason we see the discrepancies. The fluoride effects on thyroid parafollicular cell function, animal studies, almost no information. Human studies, elevated calcitonin concentration found in some but not all skeletal fibrosis patients. Significance of elevated calcitonin concentration not clear, but it is now. This was taken from a report before we did this other study. The fluoride effects on parathyroid function. Normal PTH response to dietary calcium deficiency was inhibited in one study. Some studies reported hypocalcemia, but did not measure PTH. Several studies show increased PTH activity along with hypocalcemia. The fluoride effects on parathyroid function. Probable hypocalcemic response to fluoride followed by increased PTH secretion and response. PTH is parathyroid that's being excreted in the urine, okay, through the renal system. You can't bind it. It goes out in the waste system of your deal. You don't have any reaction from thyroid. How many of you have overweight patients? They're peeing out their thyroid. It's that simple. Elevated PTH concentration, at least some individuals. Elevated PTH are clinical secondary hyperthyroidism and skeletal fibrosis. Now, why is that? Because it's causing for more thyroid to be produced. The pineal gland is saying we're not getting any thyroid, produce more. Okay? Hypocalcemia in 23% of the children with high fluoride intake versus 2 to 13% in comparative population with low fluoride intake. The same thing is seen on the children, we're seeing in the women and the men that have prostate cancer and being treated with the Fosamax or bisphosphonate drug. Fluoride effects on the parathyroid function, human studies. Hypocalcemia or decreased serum calcium in some individuals treated with fluoride for osteoporosis. Elevated PTH in some individuals. Variable response, at least two distinct set of responses. Inhibition of intestinal calcium absorption. Can't absorb it. It's not there. The reason for it is there's another protein that I'm working with called SOD1, the superoxidative dismutase. It is bound by root canal toxins to a point it can't work. It's also bound by fluoride. You can't absorb calcium. You can't transport it to the cellular structure. Inhibition of intestinal calcium absorption, not explained in terms of calcium fluoride complexes. It's very explainable. We're just not looking at the cause. Effects of fluoride on calcium metabolism, possible mechanism, indirect action, net increase in bone formation, net decrease in calcium absorption in GI tract, overall increase in body's calcium requirement. Dietary calcium is inadequate to respond to an increase in PTH, parathyroid excretion. Possible direct effects, stimulation, inhibition of the parathyroid gland, completely inhibited. Specific changes in gene transcription for proteins associated with calcium uptake. Fluoride effects on calcium metabolism, possible implications, secondary hypothyroidism, general response to any cause of hypocalcemia or vitamin D deficiency. There's another one that falls in there. Why aren't we absorbing vitamin D? Why aren't we manufacturing vitamin D? We're living under fluorescent and incandescent lights. They're not full spectrum lights 90% of the time. Clinical significance is not clear for secondary hypothyroidism due to fluoride exposure. We don't know how much fluoride each person's absorbing. We ran orange juice and found 7 parts per million in the major brands. We also ran them on oranges, just straight oranges. 4 to 5 parts per million. Clinical significance is not clear for secondary hypothyroidism due to fluoride exposure. In general, secondary hypothyroidism may contribute to a number of degenerative disease. In older women, and this is not me, it says this, in older women causes phasejaw. The National Academies of Sciences is saying it causes phasejaw in the 2005 study. Where are we now with the bisphosphonates? The stage is already set. Normal penile function. The melatonin production is inhibited. General penile peptides calcify in tissue can absorb and accumulate fluoride. Association with status of reproductive system, regulation of circadian rhythms and sleep, calcium and phosphorus metabolism, parathyroid activity, bone growth, development of postmenopause as osteoporosis. Oncostatic or anticarcinogenic effects, antioxidant action, effects on central nervous system, psychiatric disease, and sudden death, infant death syndrome, all due to penile gland dysfunction. Fluoride effects on penile function, animal study decreased melatonin production in prepubescent gerbils, normal high rate of melatonin in humans. What we've seen is earlier sexual maturation in females, where females that have been on fluorides from the time they were born and getting fluoride wrenches at the dental office, they're showing starting of menarche and menopause at age 9 instead of 12, 13 like is normal nowadays. Early sexual maturation in females altered circadian rhythm of melatonin production. No sleep. How many female patients you got don't sleep at night? Fluoride effects on penile function, human studies. No direct studies. There are some now. 2 studies of average age of menarche and girls. They say 3 to 5 months. It's actually been increased now to 3 to 6 years earlier. We've seen girls now going through menarche at age 1 I know of right now, her mother works for me, started at 8.7 months, or 8 years and 7 months. That's pretty bad, really bad. Fluoride effects on penile function, possible mechanisms and implications, could cause decreased melatonin production, could contribute to a variety of effects in humans, depending on age, sex, etc. Not enough information so far. We'll add more to that. Glucose metabolism, normal situation, insulin promotes uptake of glucose in the bloodstream. Glucagon acts to increase glucose in the bloodstream. Pancreatic islets alpha cells produce glucagon. Beta cells produce insulin. Effects of fluoride on glucose metabolism in diabetic animals. Fluoride intake higher than normal in animals due to increased water consumption. Plasma and bone fluoride concentrations higher in diabetic animals due to increased fluoride intake. And you guys and gals all alike, if you've got type 2 diabetes, you better be looking at skeletal fluorosis. Plasma and bone fluoride concentration higher in diabetic animals due to increased fluoride intake. Problem of greater retention of fluoride in diabetic animals. Reduced renal clearance. General severity of diabetes worse in fluoride-treated animals. Our knowledge of the comparative form and kinetics of fluoride is primarily limited to short-term studies of a small number of mammals using the estimates of plasma, renal, extrarenal fluoride clearances scaled to body weight. That was Whiteford all the way back in 1991. Concluded that dogs were the best pharmacokinetic model for humans based on studies of healthy young adults. In contrast, all of the studies run by the ADA and the AMA have been run on rats. And they found that rat extrarenal clearance was about twice as large. Unlike humans, rat bones do not undergo Haversian remodeling along the channels within the bone. Fluoride uptake in the bones of adult rats should be minimal. Comparison between species and within species of different experiments are complicated by several factors. With chronic exposure, fluoride bone concentration tend to increase over time. We ran some bone samples on an ASH study on an 84-year-old woman on a hip that was removed for hip replacement due to osteoporotic bone. Anybody want to make a guess at what the fluoride content was in the bone on the ASH content? I happen to have been involved in some cadaver studies over the last 10 years. How about 14% fluoride? She'd been on fluoride toothpaste. She'd been drinking and living in a high fluoridated water area. She was crippled up. She died from osteoarthritis. With general exposure, fluoride bone concentrations tend to increase over time. That's normal. The amount of fluoride absorbed, the dose of fluorides can depend on the concentration of fluoride in water consumption, the amount of fluoride in the diet. If fluoride concentration is kept constant in water, dose can vary as the animal ages. Species age at different rates, and age affects pharmacokinetics, especially bone development and kidney function. Evidence suggests that rats require higher chronic exposures than humans to achieve the same plasma and bone fluoride concentrations. It has been suggested rats might require water concentrations about 5 times larger than humans to reach the same plasma concentrations. Estimated humans incorporate fluoride 18 times more readily than rats. 18 times more when the diets are on a normal calcium diet. The comparison also based on water concentration. Water for plasma is uncertain. The fact that plasma causes part, it could change age or duration of the dose. It might be more appropriate to compare exposures than water concentration. Bone comparisons are also uncertain but appear to support rat to human conversion factor. Older rats and humans at least an order of magnitude. That's a lot, man. Our organic fluoride compounds, I'm going to go through this because they're really not important because they don't seem to affect anything. It's the residual fluorides from plastics and stuff. And although some studies report no difference in plasma fluoride concentration between men and women, others found great rates of increase with age in females. These studies are all noted here who did them. Enhanced release of fluoride in postmenopausal women is one possible explanation. Similar to our regression results of the Zipkin data, some studies have found a tendency toward elevated bone fluoride concentrations in women. Very much so. A Finnish study, the bone fluoride concentration increased more rapidly with age in women than in men. This variability might be due to several factors, include individual difference in water consumption and pharmacokinetics. So it's hard to base this on when you're looking at 2.5 or 3 parts of 7.7 parts per million and know exactly. Fosamax is a biphosphonate drug medication used for bone loss. Users of Fosamax have suffered osteonecrosis of the jaw, also known as jaw necrosis, ONJ, bisphotic jaw, or dead jaw. This painful and disfiguring condition causes jawbone to decay and die. Symptoms of osteonecrosis may lead to infestation of the jaw and exposed portions of bone inside the mouth. Merck, the manufacturer of Fosamax, failed to warn users of this side effect, and they knew it as early as 2002. Okay, now this one is important. Now listen to it very carefully, what I'm going to say here. This is my insertion into this thing because of the facts are there to support it. One of the least understood and misdiagnosed effects of bisphosphonate syndrome is extreme muscle and joint pain and chronic fatigue with no apparent clinical symptoms. How many of you have patients that have extreme pain in joints? A bunch of you. Taught you something. Other similar bisphosphonates have also implicated serious necrosis in jaw. In U.S. package inserts for both Areta and Zometa, the following information on osteonecrosis had previously been added to the adverse reaction section under post-marketing experience. Cases of osteonecrosis, primarily involving the jaws, have been reported in patients treated with bisphosphonates. The majority of reported cases are in cancer patients attended to a dental procedure. Dental procedure sets it off. Osteonecrosis of the jawbone has multiple well-documented risk factors, including a diagnosis of cancer, concomitant therapies, chemotherapy, radiotherapy, corticosteroids, and comorbid conditions, e.g. anemia, coagulopathies, infection, pre-existing oral disease. Although causality cannot be determined, it is prudent to avoid dental surgery. Recovery may be prolonged or totally impaired. The Fosamax drugs and the bisphosphonates are something you guys need to be asking your patients on a patient workup. If they're on it, you've got to treat them with extreme caution, or you're going to end up in a major lawsuit. There is a class action lawsuit has been filed. Right now, there are 2.5 million plaintiffs. It's going to be 300 million before it's over with because of the way the drugs are being marketed now. It's not going to be only Merck and the other pharmaceuticals. It's going to come back to haunt the ADA, the FDA, and individuals. The last person holding the bag is going to be the last dentist or medical doctor that worked on this patient. And if I'm trying to alarm you, you're right. Because I care about this organization. I care about the holistic dentistry and the biological dentistry that you guys and medical doctors do.